Thank you, Laura, and thank you, everyone. Thank you, Jay and Doug, and of course, our wonderful staff. I'm excited to moderate this panel, and I'll start with one of the heroes of the day, John Levin, who in his inaugural speech last week said that it is precisely when there are political divisions that the openness of universities allows us to make our greatest contribution, because at our best, we are among the few institutions that can transcend political differences, enable the exchange of people and ideas, and foster a mutual understanding. And in many ways, today's forum embodies President Levin's ideals, and in some ways, it leaves them aspirational. And in this panel, I would like us to especially strive towards this exchange of ideas. I would consider this panel a success if our panelists and our audience members left the stage moved, or at least mildly entertained about pandemic policy. There are medicines to make people more open, and I may or may not have put them in your water. But in either case, I consider my role here as facilitating openness and the exchange of ideas. Of course, my most important role is to keep us to time, and I will be strict on that. So let me set just a few ground rules. Each speaker gets 5 minutes to provide introductory remarks, and we will go in alphabetical order of last names. After that, we will have an hour to get into a meaty conversation and address the remit of this panel. How can the interests of the world's poor be better represented in the decisions of Western governments during the next pandemic? For the conversation, I will address questions to particular panelists and allow other panelists to respond and deepen the discussion. We have a very impressive panel, and I will provide very short introductions to each one of them, but consider that a very short list. You don't want to hear me rattle off all of their titles, so amplify that by about 10 to 20x for each person. I'll start with Kevin Bardosh. Kevin got his PhD in international development from the University of Edinburgh and has spent his pre-COVID years as a medical anthropologist. And currently, Kevin has been the director and the head of research for Collateral Global, a nonprofit dedicated to researching, understanding, and communicating the effectiveness and collateral impacts of non-pharmaceutical interventions taken by governments worldwide in response to COVID-19. Kevin, the floor is yours.
Thank you. So as mentioned, I'm the director of a think tank called Collateral Global, and we were set up by Sunetra, Jay, and others in 2020 after they signed the Great Barrington Declaration. And our mission is to ensure that the lessons learned during COVID are used to improve future policy responses to health emergencies, okay? And we're doing that, we have 6 different ways that we're engaging right now. We're looking at national inquiries and evaluations around the world. We're doing a lot of different scientific research. We're doing media analyses, the way the media represents stories. We're developing policy tools, we're building scientific networks, and we're engaging in education in films, conferences, and other things. And you can check out our website, collateralglobal.org, and speak to me during the break to find out more, and that's the end of the plug. But for the sake of this panel, I want to unpack our name, Collateral Global. Right? So collateral damage, unintended consequences, social harms, iatrogenic harms. We have lots of different ways to say the same thing. Good intentions often have damaging effects. And public health has a hard time thinking about policy harms. So one major lesson from COVID is one that many people in the public health community, of which I'm a part of, refuse to acknowledge. Our response to the virus caused much more harm than good. At CG, we've developed a harm framework to better help us think collectively and research and understand policy harms. And it's a big job. I mean, we're talking about 8 billion people over 2-3+ years, all different types of scientific disciplines. So the issues of causation, methodological problems, they're all inbuilt into this puzzle. Our framework has 10 main categories and over 50 subcategories. So what are some of these harms that occurred during 2020 and 2021? Lots of excess deaths not caused by COVID. We're actually not sure how many because there's not good data on that. Tens of millions of new mental health disorders. $8 trillion of lost income for workers worldwide, and a simultaneous transfer of wealth upwards of $4 trillion. A global debt increase of 30%, increasing government austerity around the world, especially in low and middle income countries. 400 million people pushed into poverty in 2022 versus 2019. 400 million people, right? A 13% increase in what's called global learning poverty. This is UNICEF data, erasing all gains in the educational sector since 2000. 350 million people pushed into food insecurity, negative lifestyle behaviors, and increases in child abuse and domestic violence, and of course, declining trust, problems with press freedom, and respect for basic human rights declined. So it's a long list, and all of those affected, most affected, young people, were least affected by the virus, so you have this disproportionality, and also predominantly in poorer countries and among poorer socioeconomic groups. And the effects are going to be long-lasting, right? Generational. So the first lesson, the COVID response caused more harm than good. The second point, the global in collateral global. So what we saw during COVID was really the most disruptive global event since the Second World War. But it was also the first truly digital global crisis. Everyone was affected intimately, but we could watch what everyone else was doing and seeing. Space and time collapsed. And we witnessed an unprecedented global policy experiment in infection control, but also, importantly, a domino effect of that. So think about it this way. Had China, Italy, the UK, and the US not locked down but pursued the path of Sweden, and we have Anders Tegnell here, do you think Uganda, India, Peru, or South Africa would have pursued the same policies that they did? No, I don't think so. So certain scientific and media elite had held disproportionate power over 8 billion people across nearly 200 countries. And these elites ignored how their recommendations would be translated from the boardrooms of Geneva into the slums of Calcutta, etc. But some countries did pursue less stringent measures, Sweden, but also Nicaragua, Tanzania, Croatia, Nigeria, and some US states like Florida. And these outliers falsify, to use Karl Popper's term, the assumptions behind the lockdown approach supported by scientists mostly in Europe, North America, and China. But there are dozens of pandemic conferences, and I've been to some of them every year, where the viewpoints expressed here are not to be found. Actually, they're seen as misinformation. And there's actually billions and billions of dollars that are supporting a different set of assumptions about the lessons of COVID. We didn't act fast enough, hard enough, and we need to do it longer next time. And you can see this in the lack of serious evaluations of harms pursued by national governments around the world, including the WHO and our main medical journals. And you can also see it in the 100-day mission that's supported by the G7 and G20, which essentially says that during a next pandemic, we lock down for 100 days. We have a mass vaccination program at 100 days, most likely supported by digital certificates, but they don't say that. So the second major lesson here is there's a strong impulse to design and follow global strategies for health emergencies conceived by elites with no skin in the game and little accountability. But countries that rejected these cookie-cutter plans actually did better during COVID, since they weighed trade-offs and policy harms. So I look forward to the discussion. Thank you.
Thank you, Kevin. Next, we have Peter Blair. Peter got his PhD in economics from Wharton in 2015 and has been studying the economics of education and labor since, with a lot of attention to the distributional effects of education and inequities. He's currently an associate professor of education at Harvard and has engaged with COVID mostly through efforts to design good recovery plans of educational and labor market outcomes. Peter, the floor is yours.
Eran, thank you so much. It's such a pleasure to be here in sunny Stanford. I love this place a lot. I spent my sabbatical here, actually, at the Hoover Institution. And I just want to commend, again, your president for the really strong stance that he's taken, that this would be one of his first conferences. And also commend my friend, Dr. J. Bhattacharya, for his exceptional work in putting this on. I thought long and hard about what I would share about today. And I want to take the global in the title of today's talk in a different direction and really focus it on the university, which is a collection of people who are coming from all across the globe, and talk a bit about what's the role of universities in terms of impacting the way that we respond to these kinds of pandemics, given that we are at a university. And this takes me back to a song that we used to sing in Sunday school. And some of you in the room might know this. It used to go like this. Deep and wide, there's a fountain flowing deep and wide. Now you may be saying, Peter, why did you sing me this trite song from Sunday school? Because we're sitting in a university where each person is an expert. They have a depth of expertise, whether it's in economics or in public health or in the law or in ethics. And we also have a breadth of expertise across all of these different disciplines. And that's the thing that makes the university a unique place within our ecosystem. Even relative to Goldman Sachs or Google, We have the depth and the breadth of expertise. And one of my earliest reflections during the pandemic was the way in which we did not lean into that depth and breadth of expertise. I remember teaching the spring of that year, and immediately my university went into lockdown. And I felt a deep sense of weight and a deep sense of guilt because many of our students were going to be going back to homes where we didn't know if they had the setup to learn remotely. We didn't know what the health situation might be in their context. But here we were, a university with lots of resources, with a world-class medical facility. And I thought to myself, gee, if there's any place in the world that could figure out how to ride out the pandemic, it would be a well-resourced university with a medical center. And wouldn't it be a great opportunity if we leverage the depth and the breadth of our expertise to say, for example, get 50 faculty, legal scholars, epidemiologists, public health officials, economists, folks in marketing, because at some point you're going to have to market whatever the public health response is going to be, to sit down and take an ecological view of this pandemic and to say, if we were to pursue this particular economic policy strategy, how would that impact the public health situation? What's the way that we message that? How do we also balance the civil liberties and also our responsibilities under the Constitution in the United States? And in part because very well-resourced elite universities are also looked up to as a standard of excellence within higher education, the decisions that they make would trickle down in the same way that the first panelist mentioned that decisions that some of the early countries that were hit by COVID trickle down into other countries too. And so I think that that's a big lesson for me in terms of how can we develop within the university a kind of response that says, what's our obligation to the society as a place that's both deep and wide in terms of assembling experts who can talk to each other because of their shared sense of community through the university. And also given the fact that so many folks are looking to us for leadership in that moment. I would say one other note too, which was that this pandemic happened during a general election. That's not something that's come up yet. And so the political forces were very tectonic during this context. And so in many ways, this would have been exactly the kind of pandemic where you would want trusted institutions that are nonpartisan, like universities, like our civic organizations, like churches, to be places where we could have the kinds of difficult conversations to balance both the science and the values that we have in terms of making decisions during the pandemic. And so one of my hopes is that as universities, that we really lean into the depth and the breadth of our expertise, especially in times of national and international emergencies. Thank you.
Thank you, Peter. Next in order, but not in order of seating, is Sunetra Gupta. So Sunetra is an infectious disease modeler and a distinguished professor of theoretical epidemiology at the University of Oxford. During COVID-19, Sunetra became known for her opposition to widespread lockdowns, and many of in the audience may recognize Sunetra as one of the 3 original signatories of the Great Barrington Declaration, a defining moment for many. Sunetra, the floor is yours.
Well, thank you very much for having me here. So Kevin gave some very specific sort of examples of what lockdowns did and what are the policies that we adopted during these last 4 years, what they've actually done. What I'd like to do is reflect upon the more general principles that underlie what I would call a sort of larger class of phenomena whereby the socioeconomically disadvantaged, the global poor, if you like, both within LMICs and elsewhere, and the children of this world are asked to suffer in order to protect the interests of the more affluent sectors, particularly adults, typically located within the higher income countries. And I think if we look at it that way, we might start to think more carefully about how we might respond to, as I said, this larger class of threats that we are likely to experience periodically. And I think there are 3 elements that are common to these phenomena. The first is, of course, the identification of a threat. So, is there really a threat at all? And to what extent is this going to be represented correctly to the public? So in the case of COVID, There was a real threat, and this is manifest, and all the data shows you that, that there was a mortality, there was a toll associated with COVID. But this threat was confined to a particular sector of the population. It was confined to the vulnerable, to those who are vulnerable, either because of immunosenescence or whatever it is that causes you to be vulnerable as you get older, or due to their comorbidities. So there's the question of whether there is, so the first step in all of this is identifying the threat, or perceiving that threat, and the extent to which it is overplayed or not. But let's say, and Chris Whitty, Chief Medical Officer, just last week, admitted that in the UK that the threat that was overplayed. It was overplayed. But in either case, if that particular first criterion of there being a threat, let us assume if that is met, then we move to the second element. The second element is the determination of a means by which to resist it. So lockdowns were put in place or put forward as a solution without any evidence at the time that they would work to halt the spread of this virus, the global spread. Now, there was a big question mark surrounding this because the only evidence that we had that it might do so came from some, I would say, slightly simplistic assumptions that were put into the mathematical models that projected what would happen. So fundamentally, what we have here is some sort of a proposition that there's a threat and we can do something about it. And as I'm saying, this applies to a broader class of phenomena rather than just COVID. And of course, this idea that we could do something about it was propagated with a sort of fundamentalist zeal. Facts and values became elided, as Anil mentioned in the last session. And it was dressed up as a communitarian position, or at least the only compassionate stand, when, in fact, for various reasons, we know now that it really was not. So we have a threat, we have this idea, often hubristic, that we can do something about this threat. And then third, what we have that's common to these phenomena is a disregard for the collateral damage. The collateral damage is also unevenly distributed, and we have, these are the three ingredients that make up this kind of an irrational, I think, and unfair, and frankly disastrous response to these sorts of threats.
For 30 seconds.
Is that enough?
Yeah. Oh, or if you want to take the 30 seconds, you can take them.
Oh, okay. I was going to say that under this framework, though, there is, I think, actually for COVID anyway, there is actually a one-size-fits-all solution. 4 years ago, we called it focused protection, but now I like to call it individual risk reduction. I think it should be state-supported, or actually what I really think at a global level is that it should be internationally supported. And I have much more to say on that, but I'm sure we can do that during the course.
Thank you, Sunetra. Next, we have Anup Malani. Anup got his JD in economics, PhD from the University of Chicago, where he is the Lee and Brenna Freeman professor at their law school and a professor at their medical school. And from his humble roots as a health economist, Anup joined the fray on COVID to lead the seroprevalence study in Mumbai, India, one of the earliest and largest in a low and middle income country at the time, and one of the more surprising, where by July of 2020, he showed that over half of the population in the slums of Mumbai already had antibodies for SARS-CoV-2. And so that was a remarkable finding. We're excited to hear your perspective, Anup.
Thank you. So thank you for the opportunity to speak, and also specifically on this topic. I want to pick up where Eran left off. I want to tell you about 5 lessons that I learned from working in India during the pandemic, one of which is going to be the one talking about the study that Eran just mentioned. So the first one, I think, is that there's not just inequality in resources across country. In the context of a pandemic, there's an inequality in the availability of expertise across countries. And so India lacked the same number of mathematical modelers per capita that places in Europe or in the United States had. And that was a challenge, I think, for them to both do surveillance, but also to interpret that surveillance. I will say there's a positive light to this, which is I had difficulty getting epidemiologists in the United States to go and focus on India, but I didn't have difficulty getting economists and physicists to drop everything that they were doing and saying, look, there's need for you to help out in India and some other Asian countries. Can you come and work with us to help provide consulting, do models, to help with surveillance? And I found that to be a very heartwarming start to the pandemic, if there was one. There's a lot of people that are willing to sacrifice to address that inequality. Number two, India made a bunch of policy mistakes, policy choices. Some of them were mistaken, some were not. I want to elaborate on one of them, but that illustrates some of the inequities that go on. So one mistake that India made, which I don't think it was alone in making, was that it assumed that the only people that were symptomatic were the ones that could be infected or could spread the infection. We now know that's not true. And so what they would do is they would just do tests, and they had a scarcity of tests, antigenic tests, on people that were in hospitals. But then they didn't get a correct estimate of how prevalent this disease was. And so we convinced the state of Bihar to do something a little different, take seriously asymptomatic threat, and we had them randomly select migrants, migrant workers coming off of trains, coming back to Bihar, figure out where they're coming from, and then test them for the infection. And what we basically found is across states, the rate of prevalence of the infection was 2 to 6 percentage points higher than what was reported in the states that they came from. This is important because we're getting the numbers wrong, but also it might also indicate that the migrant workers are a little bit more exposed. And so that was a little worry that we had about the unequal consequence of the infection, unequal spread. So now I want to go and talk about the study that Eran mentioned. And the lesson that I'm going to draw from this is that lockdowns may have some theoretical purpose, but they also have disparate consequences, which is something that Sunetra had brought up. And in particular, it is my belief now that lockdowns actually hasten the spread of infection in slums among slum dwellers. And I'm thinking about urban slums, squatter communities in low-income countries. So that's the context. So India locks down in March 2020. Locks down for almost 2 months. Soon after the lockdown ends, we were allowed to do a seroprevalence study in Bombay. I think it was one of the first done. We importantly wanted to study slums versus non-slums because slums are about 10x more dense than non-slums are in terms of the amount of living space that you have. So we do the study. We found out that 54% of people in slums have antibodies to COVID by July 2020. First case was in January 31st, 2020, so very short period of time. And only 14% of people living outside of slums have antibodies. So the huge amount of inequality suggesting that, in fact, maybe confining people into very small quarters where there are no doors very often and you have communal toilets and communal water taps may have hastened the spread rather than protect people from spread. It's also important because it finally helped convince people that we ought to be doing serological studies to track both overall exposure and potential future immunity, and we convinced the state of Karnataka and the state of Tamil Nadu, each of them as large as California, to do these sorts of surveys themselves. Number 4, we learned during the pandemic, and we learned that India had a higher death rate. When we first did our serological studies, we compared the number of people that had been infected, which was very high, to the number of people that were officially reported as having died. And those were really low. So we were under the impression at the beginning that India had 10x lower death rates than the United States. That seemed a little fishy. So we, and we weren't the only group, went out and started doing studies to look at, how can we estimate actual death rates. So we relied on a private survey that was done. It's a finance survey, consumer household survey, that goes to households every 4 months. And as part of that also does a roster that reports births and deaths. Just because you're tracking care of people. We said, let's count the deaths. And we inferred from the deaths that actually by the middle of 2021, 4 million people or more had already died, which is 10 times more than what was officially reported. And so there was a big effect. We followed that up with a big meta-analysis across developing countries, and we have concluded, I think, that the death rate, conditional on age, is actually higher in developing countries than they are in developed countries, which is not surprising, but it's something that's important to learn. There's, again, an unequal burden. Last thing, I think the economic consequences of the pandemic are a little bit complicated. The pandemic did increase poverty, but I think that it actually decreased inequality. with the exception of lockdown. So let me explain what I mean. Pandemic happens, people stop economic activity, people lose their jobs. That happens. That happens very quickly, and then most countries have V-shaped recovery. The people that go back to work first, so everybody's losing out economically, but the people that go back to work first because they have to are the poor. So inequality actually fell in India during the pandemic, and again, we document this with this consumer survey. The only exception to that was the lockdown, because the lockdown made everybody stay at home, so the poor didn't even have the choice to go back to work. And so inequality actually rose, especially consumption inequality, during lockdowns. So it's a complicated effect, certainly poverty. Inequality may have fallen, but lockdowns both increased poverty and increased inequality, and so it's something that we should think about when we think about lockdowns.
Thank you, Anup. Super interesting. Next, we have Yann Meunier. Yann is a wide-ranging doctor and expert of tropical disease and global health. He has worked or taught in New Caledonia, Nigeria, Papua New Guinea, Cameroon, China, Angola, Congo, Gambia, Egypt, Haiti, and Thailand, among others. Makes your head spin. During COVID, Yann has regularly called to avoid complacency and warned of dire global consequences without more active prevention and preparedness. I'm looking forward to this perspective. Yann.
Well, thank you, Eran, for the introduction. I'd also like to thank Jay for organizing the symposium and inviting me to be on this panel. So I have prepared 4 remarks, 4 points for my remarks. So I know that the audience is diverse, so I will start with reminding everyone that viral pandemics are asymmetric wars with, on the one hand, a viral army presenting a united front that does not discriminate in choosing human targets, and on the other, a human front with weak links. And one of the most important of these weak links is the poor, because clinically, they are the most vulnerable people to diseases, and epidemiologically, they can form reservoir of viruses. So this should be a priority for global health, and obviously it's not the case, otherwise we would not have panels and symposiums like this one. It also shows that we are not ready to face the next inevitable pandemic, as we should, despite the fact that pandemics are one of the most important serious threats to humanity, and that we have experienced a few of them already in our lifetime, but we have not drawn the right conclusions from what we've learned. Thus, my first point is a food for thought question. Why is it so? And my second one is, as the topic states for this panel, decision of Western government during the pandemic. And my second point is that during the pandemic, it might be too late. So I would suggest Western government to enact policies that help prevent pandemics in poor nations by availing more investment by them in healthcare. And let me take 2 examples. The first one is by dealing with the debt of African nations in a more relieving way. And furthermore, it would be a good foreign policy since they are turning to China in mass to find funding for their development. Second point would be by enacting legislation that would improve the ever-deteriorating terms of trade. By that, I mean the cost of raw materials exported by poor countries grows slower than the cost of manufactured goods that they import. So that increases the debt. And now many African nations cannot even reimburse the interest of the debt. They cannot invest in anything in healthcare. Since poverty is a risk factor for all diseases, quantitatively restricting access to care, and qualitatively, these would be good preventive measures because new financial resources could be used to strengthen healthcare systems and train the workforce. For my third point, during the pandemic itself, I would suggest the following 6 actions that could be action plan for Western nations. Action 1, involving these countries in decision-making from the get-go, not as a second thought. And please see how the Ebola and AIDS pandemic unfolded. Action 2, listening to them better to address the specific differentiating characteristic of each country, demography, sociology, psychology of leaders and people and languages, as well as what we all have in common. And this would be very useful when fighting same foes, like a virus, as part of a pandemic response, which should be tailor-made to fit each nation as closely as possible. Action 3, considering their perspective as entire part of the combat against pandemic, not an appendage. Action 4, addressing priorities defined by them in priority. Action 5, considering all interventions with long-term perspective, not as one-offs. And Action 6, anticipating the negative consequences of all interventions, eliminating or mitigating them as much as possible, and assessing them together with these nations afterward. And my fourth and last point is that, hopefully, the increasing use of AI will improve the calibration of policy ROI, enhancing the involvement of poor countries in the decision-making processes in healthcare globally, in terms of vision, framing, elaboration of policies, implementation, monitoring, and assessment. Thank you.
Thank you, Yann. Okay, last but certainly not least is Vinay Prasad. Vinay is a practicing hematologist-oncologist and a professor in the Department of Epidemiology and Biostatistics at UCSF to the north. He's a prolific author of books and many, many articles and blog articles scrutinizing medical practice and the use of evidence. During the pandemic, Vinay has used this experience to scrutinize public health practice with a particular focus on some real focus on things like masking of young children and guidance around vaccinating lower-risk populations. Vinay, the floor is yours.
Thank you. Thank you all for having me. Thank you, Eran. Everyone's already taken the opportunity to thank President Levine and Jay. I'd like to thank Peter Hotez for his support of this conference and publicity. Thank you, Dr. Hotez. I know you're watching. I know you're watching, Peter. Thank you. For 10 years before the pandemic, with folks in this room like John Ioannidis, I had studied medical and public health interventions that either don't work or have harms greater than benefits. So then the pandemic came and I was out of business. Everything worked perfectly and nothing didn't work the way we thought. Okay, no. I'm talking about global impact. And I think to echo some of Kevin's excellent points, the two biggest places I see the long-term global impact of pandemic restrictions will be on learning losses globally, which are catastrophic, and poverty globally, which has risen. In terms of years of life lost, we're talking about excess mortality a lot, but I think a better metric of the impact of COVID-19 spread versus the harms on young people is years of life lost, because it takes into account that a young person has much more to lose than someone in their 90s or even a 100-year-old person. And in terms of years of life lost, just from learning losses alone, we may have years of life lost that exceed COVID-19 losses 10 times, 100 times, if not more. We don't even know. One of the things that was discussed often today was school closure. I think one panelist talked about the differences between values and the science. But to me, one unanswered question about school closure is, did it even substantively slow COVID-19 spread? And the answer, Anders is shaking his head, no. And I think that's the answer was known in 2020. We had a very well-done regression discontinuity study from Germany by the fall of 2020 showing school closure did not substantively change spread. We had a study out of the USC group in 2021. An Iran study, I think, shows that we may never know, because these policy measures were implemented in such a haphazard, illogical, and unscientific manner that there will never be consensus on which interventions slowed spread and may have yielded years of life gained, and which ones did nothing at all, and which ones had harms exceeding benefits. And that, to me, is the most catastrophic long-term global impact, the sheer ignorance of what we did. Somebody here talked about putting air filters in schools, and this is a popular topic. You know, what I want to see is a cluster randomized trial of 1,000 schools to whatever HEPA filter, UV light you want to do, and see what the spread of virus is 1 year later, 2 years later. And think about, instead of all the money you spent on HEPA filters, what if you took that money and paid for more teachers or better nutrition in schools? What I want to see is evidence generation instead of just policy solutions that are unsupported. Last week, no one has talked about the most interesting news story to me, Jay Varma. Jay Varma is the New York City public health official who advised Bill de Blasio during the COVID-19 lockdowns. And New York City, famously, not only was there school closure, they had mask mandates for toddlers. They had a passport for children as young as 5. You couldn't take your kid to the to the restaurant unless the kid had proof of vaccination. They had prolonged school closures. They had draconian policies, vaccine mandates, et cetera, et cetera. Jay Varma, the New York City public health official overseeing these policies, was caught on hidden camera admitting to attending sex parties in 2020 and one rave. In other words, flaunting the very restrictions that he was implementing. He's not alone. Neil Ferguson, Imperial College London. He went with his mistress. Gavin Newsom, French Laundry. London Breed, the mayor of San Francisco. She went to party. Nancy Pelosi, hair salon. What's my point? The people who formulated the restrictions and policies and implemented them repeatedly disobeyed them. They repeatedly violated their own policies, suggesting two things. One, this narrative that we have now that we only know things in retrospect was wrong. At the time, they themselves were not very seriously concerned about COVID-19. That's why he went to the site. He was not worried for himself. He knew he was a healthy, middle-aged man, and the risks were very low. So he was not very worried. That was a different narrative for what they publicly said. Two, the people who set these policies should be distrusted because they're not using good evidence to generate the policies. They themselves set policies that human beings cannot abide by, that are antithetical to our human nature and our socialization. And the distrust in public health is well earned. In fact, I would be offended if there was a resurgence in trust in public health. It deserves to be distrusted, actually. I like the boo. Peter Hotez, you said you're not coming, Peter. Why are you here? Come on. No. Sorry. Okay. I want to talk about my own department in the last little time I have left. I'm in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. In 5 years of COVID-19 policy, we have experts in my department who specialize in early life course education and socioeconomic determinants of health, all these experts in my department. In 5 years, we have had one debate on any COVID-19 policy topic ever. One debate in 5 years. You can't talk about anything in my department. You can't talk about vaccine mandates. You can't talk about the annual fall booster recommendation that continues year over year. In San Francisco hospitals, we have an annual respiratory mask mandate, season of mandate, and no randomized data supports this. You can't talk about anything we're actually doing year over year in my department of epidemiology because it's so taboo to talk about. What does that say about the academy? That the very policies we are implementing cannot be debated by epidemiologists in the epidemiology department. It's so bad what academy has become. Why are podcasts, YouTube, Substacks, Berenson's and others so popular? They're the only places where you might hear two different points of view. You don't hear that in the university, with the rare exception of this conference and a few other conferences that have been had. And that is terrible for the long-term health of the academy. And from the global point of view that my friend was pointing out about the university, I think the more we've suppressed these voices, we've done ourselves a grave disservice. The last point, I don't think anyone's made. Had COVID-19 occurred in 2009 or 1999, the response would not have been anything like this. It was contingent on one thing we've not discussed, which was the ability for people in high-income nations to take a huge percentage of their upper middle-class workforce and allow them to work remotely on Zoom, order food on Uber Eats, and get their deliveries on Amazon. The big tech companies, which suppressed the speech of many panelists, benefited greatly from the pandemic restrictions because it allowed them to consolidate power, to put mom-and-pop businesses out of office, to make us all dependent on Zoom, to disrupt our daily going to office. This is a huge legacy of the pandemic. And had it occurred in a time when the internet was not so robust, when the companies couldn't have thrived, there would never have been a lockdown in 1999 because you couldn't have had Zoom meetings. So that the New York Times reporters who cover the pandemic, perfectly balanced, they would have been laid off if they can't come to the office. But now on Zoom, they can live their lives. So to me, how many of the people in low and middle income nations who did not have these luxuries had their voices heard and represented in these global policies? And I think that's a topic we should discuss. So thank you for the opportunity to speak.
Great setting of the stage. Okay, so we're going to have a global focus. And at a global level, there are so many different policies, as we've mentioned, and so many different outcomes that it makes you dizzy. And many here have suggested that, in fact, it makes it really hard to understand whether the policies helped delay the pandemic or help it in any ways. I want to question Kevin, Sunetra, maybe Vinay too. How do we know that it harmed that it caused any harms. And how do you disentangle, Kevin, the effects of the policies themselves from the effects of the pandemic per se?
It's a great question. I'd like to actually just point out two stats that really help build on what Vinay was saying and is relevant to this question. So how many people around the world could stay home at the height of global lockdown, April 2020? What do you think? This is International Labor Organization, UN. Best stats that we have, 17% of the world could stay home. That's 500 million people. So the idea that we could lock down the world is a complete fallacy, right? We sort of played a game of lockdown. And I've worked in Haiti for a long time. I was involved in a study there, and people are locking down in Haiti. It's like you don't really have a lockdown, right? People are moving around. And we did that here too. The other thing is, how much money did government spend on the COVID response? So this is IMF figure up to September 2021. It was $17 trillion. Okay? $17 trillion. What percentage of that went to the health sector, right? We're dealing with a health emergency, 8%. So we have a global pandemic, and 8% of the funding that we're giving is to the health sector. So this helps us to think about the whole sort of pandemic in a different sort of term, right? We implemented these infection control policies that people didn't really abide to because of human nature and sort of socioeconomic conditions. And then it was really an economic and policy crisis, right? So in terms of how do we disentangle like the effect of lockdowns from other sort of things, I would say, why is the burden of proof that way? In fact, the whole purpose of the work at Collateral Global that I do is, hey, the burden of proof is the other way. And this is traditionally how evidence-based medicine should work. Like, if you're going to say that lockdowns are effective, where's your claim? Like, you're going to have the largest reduction of democratic norms and civil liberties of a generation. Where's your evidence? Really, it's that thin? Wow. So, I mean, I think there's a lot of causative studies, and when you get into the weeds, it becomes very complicated. And so if you go to the scientific literature, you can find mountains of papers that are arguing against what I'm saying. But the thing is, when you look under the hood, a lot of these models are based on fallacies. They're based on exaggerated benefits. And this kind of gets to one of the problems in the field of global public health is, we think that we're the good guys. We're going to help. We're telling you how to be healthy. And that's kind of part of the problem. We're telling you, right, how to be healthy. And so, yeah, I mean, yeah.
This is a phenomenal point that Kevin just made, which was when we think about the early response to the pandemic, it was almost treated as if it was an economic recession rather than a pandemic. So if you take your mind back to 2020, the CARES Act was passed like pretty early on in the pandemic, and you had backslapping left and right. So you had everyone from Republicans to Democrats saying, good job, look at us passing this Recovery Act. And there was not a lot of focus on how we are going to treat this as a public health crisis. Remember, we had a shortage of masks, right? And we weren't deploying a lot of these companies to produce more masks. Like, resting aside whether the mask worked or not, there wasn't this intense focus on the public health dimensions of it, or even retrofitting schools with air filters and some of the other things that could be sensible. Kevin raises another really important point too around if you're going to lock people down, you have to think about what does it look like for you to work from home. I'm a college professor, and it was like, at the time, it was like my home was not in a state for me to work at home remotely. We sent people back who are university students back to their homes, and many of them were learning in their bedrooms. Is that a conducive environment for us to continue to learn? And so I think how you set the null hypothesis is incredibly important. And when we think about the relevant trade-offs that exist when we are changing the status quo, we need to say very clearly, and this was mentioned in the previous panel, what is our objective? What are the trade-offs that we're making? And what is the evidence that supports the prior that the policies that we're considering might actually work? And ex ante also, when are we going to stop this, right? Like, I think that the human dimension is incredibly important. I'll share one tiny tidbit. So during the pandemic, I also had the privilege of serving in the Council of Economic Advisors. And one of the things I would say that the administration did really well was it started to bring together the epidemiologists and the economists to think about the trade-off between opening up the economy and the spread of the virus. And a point that I tried to make consistently was that people can only lock down for so much. We have to give them measurable benchmarks by which if these public health outcomes are achieved, then we will begin to loosen the lockdowns. And so I think there have to be principled ways for us to pin our public policies with some measurable outcomes.
I guess your question is fundamentally, how do we know the harms are causal when some of the evidence for the benefits being causal is so flimsy, as you point out in your paper with the multiverse? And I guess the best answer I'd give you that is that some of the evidence for harms is much clearer, and the signal size is so much more robust. For instance, if you look at reports of child abuse in emergency departments, children being brought in for child abuse, how quickly that changed right at the moment of lockdown really does suggest a causal effect. Whereas if you try to model viral spread, I think that's a much harder thing to do. But if you think about what the virus did, and I think that's one thing, voluntary behavioral change to what the virus is doing. People see people getting sick, they may be less likely to go out. So that's what the natural coronavirus is responsible for, I think. Then we factor in our media coverage of it. Our media coverage is extremely biased, skewed towards fear-mongering. Somebody searched for the New York Times. I did an analysis of all the corrections in the New York Times. And did you know that when they issue a correction, 2 to 1, it's that they initially overplayed the risk, particularly in children, to create a certain fear and panic. So when the New York Times and the media is creating a huge narrative of fear around coronavirus, then you get additional voluntary behavioral change. But that's not, strictly speaking, due to the virus. It's due to the inadequate, incomplete media coverage. And then finally, on top of that, you get the policy measures and restrictions placed, which may actually have had very small impacts on even the change in meeting people face-to-face beyond all that behavioral change that was voluntary.
Go ahead, Sunetra, and then yeah.
Okay, yeah, first of all, I just want to say that I think the role of behavior change, and I think I'm going to disagree with a lot of you here, is overplayed. I don't think there's any evidence that voluntary behavior change is responsible any more than mandated behavioral change. But what I wanted to say in terms of how to disentangle the two, the first thing I want to say is how not to do it. How not to do it is to make a mathematical model that predicts what the harms be and then say, oh, but that didn't happen, therefore the NPIs must be responsible for that. That's how not to do it. But fundamentally, I think one of the things we need to become comfortable with is that there will always be uncertainty surrounding these issues. And what we need to come up with and understand is that you can operate under uncertainty. So I would completely agree, not just that we now have evidence. I think right at the outset, we knew that lockdowns, a lot of these NPIs, would cause harm. I think we were certain of that. So in fact, I often say this, we inverted the precautionary principle by saying, let's do that, even though we knew that would cause harms. And what we were uncertain about, and I think will be for a very long time, is whether these NPIs actually stop the spread of the virus, or indeed what that would have achieved in the first place, even if it had done, other than possibly allow you to wait for a vaccine. And so under those circumstances, you can still make decisions. You can say, we know the lockdowns cause harm. We don't know whether they'll stop the spread. What should we do? Well, I think the obvious thing is you don't do what's obviously going to cause harm. And within that, you can then come up with this solution that I'd like to elaborate on a little bit later, perhaps, of individual risk reduction. That remains the one thing that you perhaps can do within the uncertainties. So we don't need certainty about everything in order to come up with a policy that is going to cause least overall harm globally.
Great, thank you. And Yann.
So, Eran, I think your question goes to methodology and the validity of models. There's one model, there's another model, there's different methodology. Which one is the one that's most valid? And that reminds me of one of my teachers in epidemiology. His name was Léon de la Pessonnie, and in the English or Anglo-Saxon world is not well known, but he's the one who first described the meningitis belt in Africa. He used to tell us there is no model that can be as good as a study in the field. So this is how you know how the harm is done, it's because we're talking about poor countries. You are sent to send people in the field to assess the damage. Now, I must say this is biased because nobody wants to go, for example, to slums in Lagos. People rather go to Tanzania or Kenya with dry climate. It's never too hot and so on. But one of the first studies I did in slum in Rio, nobody wanted to go. So I was excited because I would discover I'd never been in a South African slum. And I can tell you this is eye-opener.
Can I just ask a question? Why does somebody have to go? There are people there who can do the work.
No, but you want to know, you want to assess.
Yeah, but nobody, they're there. Why are we? Why do we have to go?
I'm not saying we as Western countries. I'm saying the scientists. We as a scientist. Not. There are
scientists there.
Okay, sorry.
Who can do the work.
Yes, there are people there. That's what I'm saying. But they don't want to go into the slums. No, there's a reluctance. Okay, well, I was there. I can tell you from experience that they'd rather go study obesity, for example, in Ipanema than go to a slum and study, for example, that's what I did, about the habitat of the bug that transmits Chagas disease. You have to go into, this is not pleasant. That's all. It's a subjective thing.
Yeah. Well, so Yann, you mentioned earlier about listening to LMICs, and Anup, you mentioned the lack of capacity sometimes in partnering with your colleagues in India. When we are having in this, in the midst of this global pandemic, who's going to speak for the LMICs? Who are going to be, if there are very few scientists, who are going to speak for them? What's the role? And in that, I kind of want to get your feeling about the role of the World Health Organization, whose reputation maybe is even taken a worse battery than the CDC. It's a high bar. But I want to get your sense of how can we get the voices of LMICs more into the conversation?
So actually, do you mind if I just quickly add into the
Yes.
last discussion, then I'll answer your question. So you asked, what is the burden of proof? I want to first push back on a few things that my co-panelists have said, provide some data, and then say that the answer to your question is not easy. So the first thing is, it's not obvious to me that we wouldn't have had a massive reduction in economic activity, even in the absence of mandates. And the best study on this, I think, was done by Chad Syverson and Austin Goolsbee, who compared, did a border identification across states where, one side of the border you had a lockdown, the other one didn't, and both of them experienced very similar economic activity reduction. And so you're going to have some voluntary response. Now, for those people that say, see, mandates are good, you'd say, well, actually, you didn't need mandates to do it. But the people that are going to say mandates are bad would also have a difficulty there because people would have curbed their activities. Which leads to the question, well, why do we do mandates? And I think that's the question we ought to ask. We're acting as if we're saying mandate is a choice. No, I think the mandate is the result of some sort of process, a human process. In the last panel, I think Neil had said we heard. Whenever there's a crisis, we heard around something. We might have heard it around policy solutions, even if it was premature. We need to do something rather than another thing. Which then gets us back to, okay, what's the burden of proof? Should we say that people who want to do mandates have burden of proof, or people who don't have mandates have the burden of proof? And I don't know if there's a natural answer to that. Obviously, your priors are going to make a difference. If you're opposed to mandates, you're going to think the other side has that burden of proof. I think what we ought to ask ourselves is, well, why did politicians do this? And one super interesting fact, basically all red and blue states enacted mandates in the United States at the same time, within 2 weeks. It was a herd. And the question is why they did it. And I think part of the answer is, if you don't do anything, you look like the person that didn't do anything. So if there's calamity, you get into big political costs. But if you do something, they can't blame you for trying. Which then gets us back to okay, so what should we do in low-income countries? I think part of the answer is, and this is true about comparing different states, whether it's states within the United States or nation states, different countries are going to do different things because of different value systems. And at some point, we have to delegate to those countries, whether it's Sweden, whether it's the United States, and people have to make those choices because we're not in a position to tell India exactly how they should weigh prices of economic activity and poverty against the risk of infection. We certainly might care because the disease might spread to us, but we have to take into account their preferences. I think the one thing we can do, I think, and we should try to do next time around, is build local capacity to have the local scientists go and do the work and not necessarily have us go in because we don't only bring in our methodology, we bring in our preferences, which may not be appropriate.
How about in terms of getting, speaking for LMICs and bringing them more into the conversation? Maybe Yann also, because so you certainly have your experience with WHO and the
building up capacity. Building up capacity.
Either that or having them more directly involved in the conversation of global policies.
Well, you know, we have to call them. I mean, we have to invite them to the table and take seriously what they have to say. And stop having this condescending approach that we're going to teach you. This has been going on for decades, and it is pervasive today. So treating them as equal, listening to them, taking their priorities into consideration as the priorities, because, as I said, this is the weak link. The poor nations are the weak link of pandemics, because they form reservoirs, and also that's where the mortality is highest. Now, in the case of COVID-19, it's not totally true, because you can see the mortality rate in Africa is much less than it is here. But there again, when I said that, I was taxed as being what's a colonialist mentality and so on, when I said that the statistics coming from there are not reliable. And you know that the statistics from African nations and so on are derived from models from scientists in Geneva in their office in air conditioning, and they design the model, and they tell you what's going on in the villages in Nigeria. This is nonsense.
Yeah, I don't think the WHO is tasked for this. They speak only on behalf of themselves. Yeah. They want to consolidate power. Right now they want an agreement where every country has to do whatever they say. And what they say is is not based on any science. They didn't run any randomized study. Did they run a single randomized study run by WHO on non-pharmacological interventions? They have their medicinal studies that tend to prioritize branded pharmaceutical drugs, but they did not run any of these studies, and I think they have no legitimacy. And as you say, their standing is lower than the CDC. The CDC that brought you cloth masks for 2-year-olds, except when they nap side by side in the same room, then they can take them off. We have an agency of 40,000 people that made that policy recommendation that was enforced by law by Biden's Head Start. And the fact that nobody in CDC wrote countervailing op-eds, nobody protested that, of all the things I got as a UCSF professor that got me in trouble. I wrote an article in the fall of 2021 at the Atlantic magazine saying that young kids shouldn't mask. There were hundreds of requests to the chancellor that I be fired for writing that article. I think that speaks to the massive propaganda campaign that was run. To even think that a 2-year-old, you should worry about your 2-year-old at all, is already ludicrous. And then to make them wear a cloth mask is even more ludicrous. And then to think somebody who disagrees with that is providing misinformation is the most ludicrous thing of all. So I think the WHO is ill-suited for that.
Well, and if you want to assess the damage and the dismal state of global health, WHO cannot get an agreement on which they don't have no implementation power. So even if there was an agreement, who's going to do it? And they have no leverage over any nation, particularly China.
Yeah. Let me, it gives a...
Actually, it's totally depending on China for the funding.
So if I could...
let's have Peter first and then go.
I'm wondering, Eran, if the preference heterogeneity that Anup mentioned gives us the opportunity to do experiments in real time, which is something I think that Vinay was alluding to, right? So say, for example, if you were to convene people from various nations and you said, okay, here are the things that we need to know about the pandemic, and here are our cultural practices, here are political constraints, X, Y, Z. There might be some places that might be willing to do randomized trials on masks. There are other places that might not want to do that, right? On vaccines, et cetera. And we could actually leverage that for generating interesting scientific insights in a way that also leans into consent, right? And the thing that would have to be a maintained assumption is that science is science everywhere, and that the things that we learn in the developing world could inform policy in the developed world. And I think as long as we have that maintained assumption, that the preference heterogeneity actually helps us in real time. The last thing that I would say is we would need to backstop that with resources to say, if you're a country that is willing to engage in experimentation in a safe and reasonable way, that we have a pot of money that allows you to do that in an effective way.
I think randomization is always possible, but you need the leaders who go on television to tell the public there is uncertainty. And you didn't have that. You had Fauci one day saying they definitely don't work, you touch your ear, and then the next week like, oh, well, of course, cut your T-shirt and put it on your face. It's a miracle, and I don't know, I didn't figure this out 6 weeks ago. That level of dishonesty from a scientist, because surely he knew the evidence did not change. Surely he knew the consensus of the randomized trial evidence before. You need a leader to go and say, we genuinely don't know. we're going to be randomizing your county in the next week, and we're going to need you to pitch in, help out. And if you do in one county, don't do the other county, we'll answer this question in real time. Same with school reopening. They could have tried a variety of strategies, from cohorting to the 6 feet of distance, which now they all deny that they came up with when they were happily going on TV telling us to stand 6 feet apart. But you need leaders to acknowledge uncertainty, and they never did that.
Let me get Kevin and then
yeah, so this is a big issue around politics and real politics, right? And in terms of the distribution of power within countries and between them. So a lot of global health is funded through foreign aid budgets. The US gives $10 billion plus a year around the world to different countries. And with that comes strings attached. And some of those are often implicit, they're not explicit. You know that you've got to toe a certain sort of line. You have bosses, you have things that you're allowed to say and not say. And it's similar with EU funding, and I would say more and more with Chinese funding. And so the idea that, oh, well, we just need to give more money to LMICs and that's going to solve the problem. No, you're creating a different elite in India or in Nigeria or wherever who have to answer to the metropole. And with that, there's an issue around biomedical expertise. So I'm sorry to say, I'm a medical anthropologist. Doctors can be great. They can also be incredibly arrogant, okay? Anthropologists as well. Actually, we're all susceptible to this. But in medicine, there's a particular kind of bent around expertise and sort of know-how and a vision of the world, a sort of command and control, militaristic almost mentality that can take over, especially during emergencies. So I think there needs to be a dismantling of that perspective. And I do agree with what you're saying in terms of doing these retrospective evaluations. I think that COVID is really an opportunity, let's say, for African countries to take stock of what happened. And it's unfortunate that the WHO can't do that because they're the ideal body. Unfortunately, they've succumbed to this issue around the power that comes with money and the biomedical gaze. So there needs to be some sort of reinvigoration of the international or sort of order or institutions that can do these types of evaluations and support capacity building.
Let me ask, many of you have expressed ideas about what the policies could have done or what are some of the sources of the way the policies happened. Many of the policy programs that you and others have suggested nowadays look eminently reasonable and in hindsight have kind of been adopted by many who opposed them earlier in the pandemic, things like focus protection and unmasking of young children. Now everybody says it was a good idea. Counting natural immunity as equivalent to vaccinations. All of these, one can point to many reasons why, to try to understand why they were not part of the mainstream policies. I want you to reflect a little bit about your role, and many of you have been in a more skeptical. What do you think you could have done different in order to enable these ideas to become more part of the mainstream policymaking process? Or universities?
Are you looking at me?
We'll start with you, Peter.
I'll put myself on the spot. Yes. I think in hindsight, I do feel really guilty that I didn't say something earlier on. I felt terrible when we announced that students who had already left for spring break should not come back to campus. Their stuff will be packed up, and that faculty should flip their classrooms to remote. And I just felt incredibly gutted. And for about a week, I barely could eat, I could barely think, I could barely sleep, because I was on the front lines of being a part of enforcing, or implementing is a better word, this kind of policy. And the idea that I mentioned in my opening remarks, which was that this should have been exactly the moment when we used the depth and the breadth of the expertise of the university to get a group of faculty together to start thinking not just about how can they advance their research program, but how could we serve in the national interest, right? And I think that that was one of the reasons that initiated me to reach out to Jay when he was coming under attack by people who I know and respect very much. I'd say the other thing that was a bit more redemptive was being able to serve in the administration. One of the reasons why I did that was because it was an opportunity to do that. Now, within the administration, something that I thought maybe I could have pushed for a lot more was I thought that lockdowns without any end in sight was unrealistic, and I tried to push the argument to say we need to tie the slackening of the lockdowns to certain vaccination rates and metrics. It's hard to do that very forcefully when you're working with a team, and so I think maybe we should train academics also to be more effective at public communication, working within organizations and bodies that are inherently political to be able to get sensible ideas more to the fore.
And Anup, thank you, Peter. I'm particularly curious about your experience because you served on the COVID Crisis Commission, maybe still do. And that obviously, you have tried to, in some ways, work more with more of the, I would say, mainstream policymaking entities.
Yeah, so I think what Eran's talking about is there was an effort to try to stand up a COVID commission in the United States, at least do the background work to stand up a COVID commission, and funded by a number of foundations and led by the Miller Center at the University of Virginia. And we weren't able to actually convince folks to do it, and so we wrote a book, The Lessons from the COVID War. And we learned a ton, by the way. I mean, this was an attempt to interview tons of public health folks that were involved in decision-making, CDC, state, county officials, folks at the pharmaceutical companies, folks in the government, critics, governors. We learned a lot, and the goal wasn't to blame, but just to say, why did they make the decisions they did, and what can we learn going forward? I don't feel guilty that we didn't do more, and I think one of the reasons is we really tried to try to stand up a commission, try to learn from it. I tried to push for making sure that it's not the commission, but also there's some dissent from the commission, because we don't, even if we went back to the COVID crisis and said 3 or 4 years later, do we know what should have done? I think we're in a disagreement. That's what this panel is about, to some extent this conference is about. And so some dissent is good, but I think that we still have to do that. I'm at a loss figuring out what you can do. I mean, I think that they're political, nobody really wants to do it politically. And I think that's an issue. But earlier you asked some other things, and what could you do more? And I think I would say 3 things that can be done more. One is, I think we, again, thinking about helping other countries and not just the United States, maybe to some extent states within the United States that are less well-resourced, I think we could do more training and set up better infrastructure for these countries. And we have to do that ahead of time. We can't do that in the middle of the crisis. It's too hard. The second one is, I think I basically agree with Peter. I think that we could have done a little bit more to encourage discussion and debate and support for people who are dissenting. I think it's easy to be cowed by the majority. And I think the last thing is, even if you couldn't stand up a commission in the United States, I think it's important for us to stand up commissions in other countries so they can see what they can do going forward. I mean, there are 200 or so countries. They all need a response. The world is not oriented around the United States. And I think we should try to do more. I don't think it should be the WHO, because we don't want a consensus approach. What we want is each country to decide, hey, what could we have done given our preferences, given our resources, that would be appropriate for us and for next time.
Terrific, thank you. Anyone else?
I don't know, honestly, in the beginning, I remember watching Scott on TV, and I thought a lot of what Scott said was right. And he was also very nuanced. I mean, Scott spoke very carefully when he was up there, which I don't think he gets enough credit for. Acknowledging the uncertainty around masking and kids in schools. I mean, Scott was the first to say it, but he was standing next to Trump. And people, including some people I heard earlier today, suffer from Trump derangement syndrome. Anything that Trump says is wrong, even if he happens to be right. And I think that unfortunately carried over on Scott, and that's why the Senate voted irrationally to censor him. So I did a podcast on it. When John was getting a lot of criticism in the beginning, I tried to do a couple episodes with John, and I made as many op-eds and videos as I could. I also was trying to do peer-reviewed literature. That was so hard. Now they're getting accepted, the papers that Tracy and I and others here were working on. But at the peak pandemic, you could not get a viewpoint or a commentary that went against the grain accepted at any major medical journal. And I tried to push it as much as I could, minimizing the number of times the boss spoke to me. Taking as much as that, but minimizing the probability of being fired, because I thought it'd be less effective outside of university. But I think it was an extremely tough time. And I heard somebody say it earlier today about all the local public health officers who were harassed. And Nature did a lovely story about the local public health officers who set some of these rules in place that I disagree with, and they were harassed. And I think that's not right. They shouldn't harass those people. But I think no one was harassed worse than some of the people on this stage, than some of the people in this audience, who had the foresight to go against some of these sweeping restrictions, including yourself. I think that's a lot of brave people. So yeah.
Let me follow up with you, Sunetra. Thank you, Vinay. The Great Barrington Declaration, one of the, proposed focused protection of the vulnerable and lifting lockdowns. One of the key challenges of the Great Barrington Declaration was that the suggestion for focused protection didn't come with many specifics. How did you suggest protecting the vulnerable in a kind of very practical sense at the time?
Well, first of all, it's not. I mean, also, can I just quickly say about your previous question that, you know, if you go down the evidence-based route, we must have done something wrong because no one listened to us. So I don't know what we did wrong, but we certainly didn't get it right. With regard to focus protection, there are two things to say. First of all, it's not it's not at all correct that the Great Barrington Declaration did not make any concrete suggestions as to how it might be implemented. But at the end of the day, it was, you know, it was a sort of strategy. It's the specifics of it needed to be worked out. Having said that, I have thought more carefully about that, and which is why I think I would like to replace the word focus protection with individual risk reduction. Because I think one of the problems that we have that has beleaguered the whole kind of understanding of non-pharmaceutical interventions is that what works at an individual level doesn't just scale up like that into the community. So you can protect an individual. You can't use those same measures to stop the spread. And this may seem counterintuitive, but actually there are sound theoretical epidemiological reasons for that. So fundamentally, what we know we can achieve, again, what do we know and what don't we know? As I said, we have great uncertainty about whether NPIs can actually stop the spread or even reduce it in any meaningful way. But we do know that we can protect the individual. It stands to reason that if you stay at home, if you don't contact too many people, you can reduce your own risk. So knowing that, the sensible thing to do is to try and protect those who are vulnerable using those methods. Now, how do we do that? Obviously, there are a large part of locking down, in fact, did involve focus protection in the sense, or focus protection it's a subset of locking down, so it's kind of ludicrous for people who were advocating lockdowns to say, oh, but you can't protect people, because if you stay at home and have your groceries delivered, you are reducing your individual risk. But the question is, and then there are tricky situations like, what do you do with people in care homes? What do you do with multi-generation families, etc., which need to be worked through, but that's what we do. In wars, we evacuate vulnerable children. I mean, we can think of ways in which we can make sure that the care workers in care homes isolate themselves for a period of time, go into the care home, work there, and then leave. You know, you have this sort of cycling. But just to come to the point of thinking of it as individual risk reduction, then you think of what else should it be, this individual risk reduction? I think it should be state-supported. Whether it is voluntary or mandated is not something that actually particularly concerns me. I think as long as a mandate is actually part of a social contract, I don't think one needs to shrink from that word in the way that people do. That's my opinion about mandate. So it could be either voluntary, state-supported, individual risk reduction, or if you think the health system's about to collapse, we've got to do something, then maybe you mandate it for a while. These are issues we must consider without getting tangled or just polarized just by virtue of whatever our own proclivities are concerning liberties or intrusions into our personal spaces. But the other thing that I started to talk about was I think we should go beyond state support to think of international support. Because one of the things about focus protection that I used to stumble on is, how do you do that in India? Or how do you do that in a country that doesn't have the means to do it? Well, the country may not have the means to do it, but internationally, if we gave them the aid, they might, I'm not saying it's certain, be able to implement it. Focus protection, paradoxically, actually also may be a part of some kind of lockdown strategy in that you could say, okay, let's lock down for 2 weeks because that's the only way and the most efficient way of achieving focus protection for a short period of time. Finally, also in terms of protecting remote communities, one could bring in things like border closures, which were used in particular ways and used by countries like New Zealand in a sort of self-congratulating manner to say, look, here we are, look how well we've done.
To me,
if we had an international community, we operated under truly internationalist principles, we could have had a kind of understanding where we said, okay, well, you're a remote community. Why don't you keep your borders closed for a period of time while we try and make a vaccine that would protect the vulnerable? Maybe we could do the trials in your country. We could have had a much more connected up internationalist response, which didn't sort of, instead what happened is we ended up with this sort of league table of who did well and how, I'm not going to let COVID rip through my country. I did well, we did well. I mean, it was pediatric, to say the least.
To me, it was always unfair that people faulted the GBD for not having a 20-point plan on how to have focused protection. They faulted them. The people who supported school closure, where's their 20-point plan on getting 30 years of learning loss back? They didn't have a plan for that. And so in the spring, the key thing was, when they put out their proposal, it was really a call to engage in a dialogue. There could have been a series of committees commissioned to try to investigate different thought processes behind what would that look like, should we reopen school. But as you recall, Francis Collins sent Fauci an email saying, we call for a swift and devastating takedown of this fringe epidemiology group. They didn't want to have the dialogue. They didn't want to have a discussion about could there be school reopening for elementary schools and focused protection on the older people. And Fauci himself went on TV in April of 2020 when DeSantis reopened schools, and he fear-mongered repeatedly that that would be dangerous. And that led to prolonged school closure in LA and San Francisco.
During the recent COVID inquiry, I was asked for a witness statement in which I stated this thing. I was not asked to take the stand, but all the questions that we'd raised, for example, concerning focus protection, were posed to other people. So I had Angela McLean answering the question, well, Sunetra Gupta thinks that focus protection might have worked, to which she replied, oh, well, we considered that very carefully and decided it wouldn't work. So this is the level of discourse and dialogue that's going on. So,
Like Peter.
I suppose one challenge I want to issue to the room is that we ought to think about the politics of a situation and the communication frictions. I do think that in conversations that I've had with several people in the room, one of the things that I've said is that how we communicate difficult messages is really, really important. And I think sometimes as academics, we focus so much on being right as opposed to being understood. And I think that that's a mistake that we make, and that's something that we all in this room, I think, ought to check. I'll share what I think was a bit of a success story during COVID. So during this time, there were also in parallel, a lot of the Black Lives Matter movements, right? George Floyd was brutally murdered. And then you had a lot of CEOs saying, oh my God, America's racist. What are we gonna do about this, right? And I had been working a lot on labor market policies around how can we open up pathways for workers without college degrees. We call them STARs, or skillful alternative routes. And so during that moment, we wrote an op-ed that was published in the Wall Street Journal around how companies can do more than just giving money to causes, but they can reform the way that they change the labor market practices, right? And I knew that writing about this as somebody who has a PhD, is working at Harvard, and is working at an education school to say, how do you create pathways for mobility for people without college degrees, that folks are gonna be like, this guy's crazy, right? And I actually like that challenge because it forces me to think about how do I communicate very clearly to the people who are most likely to disagree with me, but who are open to at least evaluating the evidence, right? And I think one big learning from the COVID experience, especially for the people in the room who ex post facto have been right, is to say, what are ways in which we could have honed the message so that it could have been heard in a way that people could have understood? I definitely think that that is a margin for improvement. Now, maybe it is the case that that shouldn't fall on the people who are producing the science. And perhaps consultants should be engaged, or people who are faculty in communications departments should be engaged. But I mean, that's one very simple fix that could have helped the political process not to make the colossal mistakes that it did make. And I think if we don't walk away from this conference with a clear understanding of the value of communication, especially around very contentious issues, then we're lost. The second thing that I would say is the political structure in the United States and in many countries, by virtue of being very federal, very federated into the states, creates an opportunity for tons of policy experiments. And there's so many other situations where we say, let's give it to the states. And so I can imagine a message that says, we have a public health crisis, let's put this back in the hands of the states. Let's put some of this back in the hands of the school districts. That could have had a resonance in certain quarters, and it did. And so the communication, the messaging is really important, and then understanding how that then integrates into the political structure as a potential implementation vehicle is a critical learning in my view.
Thank you. I'm going to take a couple of questions from the audience, and to follow up on this notion of generating evidence and figuring things out. Many public health recommendations, like for example, about smoking or seatbelts, did not come from randomized trials or any trials at all. And so why require them here, especially at the start of a public health emergency? And a related question to that is, will people even agree or consent to be randomized during, at the time of such a crisis? Kevin, what do you think?
Well, we did have a pandemic influenza plan, 2019 WHO document that actually evaluated the evidence for NPIs, and most of the stuff that we did was not recommended. So there was some a consensus around the evidence for pandemic influenza. Lockdown, school closures, all test and trace, all these things were not recommended. And that was also based on this, I would say, like a conservative view of intervention that we've talked about, the precautionary principle, et cetera. And so I think that this wasn't a sort of policy response that had it had a blank slate. There was no blank slate. That's a fallacy. Yeah.
I don't know, I hate this criticism because it shows an ignorance for how many randomized trials have been done historically and what they've been done in. There were 16 randomized trials of masking prior to the pandemic, and there were at least 3 done during the pandemic. Could there have been more? Of course there could have been more. There could have been randomized trials of 3 feet versus 6 feet, randomized trials of cohorting classes versus not cohorting classes, randomized trials of whether you should have walked one way through the store or not. There could have been randomized trials of all these things. It's very easy and feasible to do. The problem is you needed somebody to admit we don't know the answer, and nobody would admit that. The people making the decisions wanted to project complete certainty, and that's antithetical to randomization, And so I don't think the question is valid. And I think what actually worked? Even the proponents who think some of these things worked, I urge you to tell me what worked, when did it work, and when does it work in the future? They have no answer to the question. They have no evidence they've generated. 5 years later, $26 trillion or more, you gave a number halfway through. Yes, how many trillions now? It's been like 30 trillion probably. We don't know anything. And the next pandemic, if it comes, when it comes, no one's going to know what to do.
So are you advocating for just more humility on the parts of leaders to kind of acknowledge uncertainty in the way that Sunetra was saying?
Yes, and I think Andrew Neumer made an interesting point, which is, why didn't they have that humility? No? And I think the fourth panel might be why they didn't have the humility. The fourth panel might be the real root of their lack of humility and wanting to take strong action when you feel perhaps culpable for what happened all along.
Anup, as a social scientist and Sunetra as a modeler, what do you think about the role of, what's the evidentiary basis that's needed for this kind of policymaking?
I'll let you go first.
You go first.
All right, first of all, look, I think we need to be more realistic. First, we can't do RCTs for lots of things because it's not feasible. It's just really hard to do. It's a very expensive form of learning. We can learn basically most of the things that we learn about are not RCTs. And so we should be able to use observational stuff. But the other thing to think about is sometimes you don't have time. You're sitting there, there's a pandemic at your door, and you have to make a decision. And we have to appreciate that people are going to feel for political reasons or moral reasons that they're going to have to take actions. And we have to be realistic about that.
Which pandemic restrictions could we not have done a randomized trial of?
I'm not saying that you couldn't have done a randomized trial. I'm just saying that
which ones could we not have done? Name one that we could not have studied randomized.
You're not listening to me.
Yeah. You're saying that there are some that you can't.
You can. The price is very high.
Price, monetary price? Which price?
Monetary price, time price, getting it organized.
What's the lowest price a randomized trial has ever been done per patient randomized?
I don't know. I don't know what the universal
randomized trials, $50 per person in the Netherlands. Randomized trials do not have to be expensive.
I do randomized trials for a living. They're incredibly hard. They take years.
They can be
very hard to recruit for. It's very hard to keep to protocol.
How do they do
It's very expensive to figure out whether or not your survey is exactly done right. I just think in practice it's harder. And I encourage you to talk to people that have done randomized controlled trials. If somebody says it's easy,
no one's saying it's easy. You're spending $27 trillion and you can't do any of them.
Hold on a second.
You can't do any. That's a disgrace.
$27 trillion is not money spent, it's money lost.
Yeah. I don't think
you can't just
some
turn
of it
around and
was
say that
spent.
that's a research budget.
Some of it was
I don't
spent.
think you guys are disagreeing. I think what we're saying is that we need evidence from RCTs, but that there are other ways of knowing,
Yeah, but the
forming
problem
priors and making
his
policies.
paper shows you'd learn nothing from the other ways. I mean, explain what your paper shows.
Well, I think
I think that would have a huge impact on the way we do scholarship if, in fact, that showed that we can't use observational data for studies. I think it's certainly premature, but I think that if we're honest about it, we'd say there's valuable learning from both. And we should try to do what we can, but we should also appreciate that sometimes you got to make decisions before you have the information. And then we got to think about, in that context, what would we encourage people to do? And that's a conversation we should have, and I think we all agree that we should have a conversation. I don't know the answers, but we should have that conversation.
Okay, well, we are unfortunately coming close to an end. So I would like to give everybody just one kind of 30-second, 45-second kind of summary of your takeaways, and then we'll wrap it up. So why don't you go first, Kevin?
Yeah, so I lead a think tank I think about this every day. And I would end, a lot of human action is based on stories. Who are we, meaning of life, what groups do we belong to? And so we have this conflict of story right now within the global public health community, right? So if there's another pandemic, I think we're going to be locking down, we're going to be pursuing those policies because the predominant sort of people that are in charge and the funding streams are still very supportive of that. And so like, you can look at, for example, Bill Gates' book on pandemic. I forget what it's called. It's all in your local libraries. And you can see there the harm of lockdown. He has this graph. So this is the level of evidence that we're dealing with. The harm of lockdown is like this. The benefit of lockdown is like this, right? So Bill Gates is operating with that level of evidence to make claims, and he has huge amounts of money, and he's advocating for this sort of global fire brigade for pandemics, 5,000 people that should be funded annually. And there's an immense amount of groupthink in there. So I think that we need to break that narrative, that story in biosecurity right now, and that's what I sort of spent a lot of my time thinking about.
Thank you. Peter.
I would say a big learning for me, even looking at the broad agreement and also disagreement that I've seen on this panel, is the importance of relationships and creating third spaces before these pandemics happen. And creating ecosystems where we could have conversations, we can debate the evidence, we can bring experts of different kinds of expertise together to form a multidimensional approach to these sorts of issues, because it's both a health crisis, an economic crisis. There are social implications of this, and I believe that universities are very critical spaces because of the depth and the breadth of universities. And within the context of universities, this should be something that's rewarded, that's encouraged, so that at a moment's notice, we can stand up a group of Avengers, not just only within a given university, but I think also across universities. And maybe this model too should apply to nations, where we're building these robust networks of trust and deep expertise so that there can be a free flow of exchange of information. And also, if we need to generate evidence, we can generate that evidence using shared administrative data or RCTs as the methods would allow.
Wonderful. Thank you so much. No.
4 things. First is amen to what Peter just said.
Totally
I think
amen
that we need to have an interdisciplinary approach. Epidemiologists have an important role, doctors have an important role, they have different voices, economists do, political scientists do, sociologists do. I think that it's important to think about each of those perspectives and not just say there's only one group that has expertise to make pandemic policy. It's a multifaceted issue. Second, we have differences in preferences over what we value. Simple way to think is, do I value my health or work? But there's lots of other things involved, freedom, et cetera. And we do need to understand that humans are diverse and we have different preferences, and we might come to the same answer even if we have the same methodology because of those weights. And we need a method to evaluate that. Third, politics are always going to be relevant. Right? To ignore politics and just say we're just going to follow the data or we're going to just wait until the results, I don't think that's empirically going to be that's not going to predict what we'll see in our behavior in the future. And the last one, which is super important, which actually gets back to an important question that Sunetra brought up, which is state capacity. I think that in the United States, we're used to having a really high state capacity with lots of money and we can do lots of stuff. But in lower income countries, they don't have even basic data. So we don't know, we can't be informed in our decision making. And I think that it's going to take time to build up that state capacity. That's the fundamental problem of development. Until we do that, we have to understand that we're going to make decisions or not make decisions with a great deal of uncertainty.
I agree. Sunetra.
Just 2 points. I agree with everyone that we need a forum for more mature dialogue. I mean, what we saw during the pandemic was a lapse of critical thinking, and in some senses, the role or the goal of Collateral Global is to establish the conditions under which we can have more mature dialogues about all of these. Just on the previous point about RCTs and observational studies and whatnot, I can understand you can't do RCTs for everything, but I'd like to beg you all, whoever is in the business of doing RCTs, can we please do some RCTs for focused protection? Because that's what, we want. We want to gather. There's a huge emphasis on let's look at whether the NPIs worked or not. I mean, really, I would say, I think it's pretty clear they didn't. Or it's so hangs in the balance. It's almost, if we have a limited amount of resources, can we look for solutions? Can we do RCTs on proposed solutions?
Right. Thank you, Sunetra. Yann.
So when the COVID-19 pandemic came, humanity entered into a tunnel. I mean, in many ways, in many metaphors, you can say we're still in the tunnel because the virus is still around, and who knows, maybe a variant will become completely resistant to curative and preventive treatment one day. So those panels were very interesting, intellectually stimulating, great expertise and so on, but I don't see the light at the end of the tunnel. And I am very worried.
Right. Shouldn't be.
No.
So if I listen to you, you promise me that you will...
There will be no new variant.
Oh, yeah.
That will kill us all.
They keep popping up every week.
Yeah,
every
that's
day.
what they're supposed to do. But have they killed anybody yet?
No, but I say
Evidence.
There is a probability. It's a matter of probability. It's a Russian roulette.
No, it's not.
Oh, so what is it?
We'll have coffee after this.
Yeah.
Settle this. Okay, go ahead, Vinay.
First of all, I'm sorry for my cough during this panel. It's just COVID. Don't worry about it. No big deal. No big deal. You walk it off. No big deal. No, I guess this panel was about a global perspective, and I think to bring it back to the global perspective, I would say the globe has been, I think, decimated by many of the pandemic choices made by a handful of elite people in wealthy Western nations, and we'll see that in terms of poverty and learning losses and many of the things that Kevin has detailed in reports. And I think whether or not the globe gained anything from any of the restrictions they placed on their people is absolutely uncertain. I'm not sure they gained anything. I know that they were severely harmed as a result. I worry that there is a fundamental disconnect about what counts as evidence, and I respect their opinions, and I've only done observational studies, so I do think they're useful, but for making causal conclusions about the efficacy of things with modest to marginal effect sizes, they are very useless, especially when confounding and noise is so prevalent. And I'll just summarize his study as my closing thought. His study, what he did was he took data from all the countries of the world, and he took all these restrictions we implemented, like school closure, lockdown, travel restrictions, et cetera. And what he said was, somebody will come along and run one model where they adjust for a couple of covariates, and maybe they'll keep a couple of these things in the model. Someone else will come along and adjust for a couple different things, and they ran 100,000 different analytic plans. And they get every answer you'd imagine. Yeah. Sometimes it helps. Most of the time it doesn't do anything. Sometimes it was harmful. And that's what the debate is going to be in the next 30 years, on masking, on lockdowns, on boosters. And meanwhile, I'm going to get an annual email every year to do all these things, and no one has any evidence to offer. And that, to me, is the greatest failure of science in the pandemic, just that we don't know the answer to fundamental questions that we're going to keep debating.
Great. Well, join me in thanking this panel that really embodies